Hello and welcome everyone to this webinar that it's organized by the Max Foundation together with the Advanced Breast Cancer Global Alliance. We are going to discuss the issue breaking down barriers, enhancing cancer medicine access in low middle income countries. So as you probably are aware, these two organizations together with other partners, we are working in a very important project for us, which is called the Humanitarian Partnership for Access to Cancer Treatment, or for short PACT, Humanitarian Pact for Advanced Breast Cancer. And today we're going to share with you some of the insights we have learned since we have started this program. Next slide. So these are the speakers of today's webinar. We will start with Pat Garcia Gonzalez. She is the co-founder and CEO of the Max Foundation. We'll then move to Dr. Alexandra Eniu, a medical oncologist, originally from Romania and now working in Switzerland. We will then go for Ms. Carla Ruiz de Castilla from Peru. And I will finalize with some take-home messages. I'm Fatima Cardoso, medical oncologist from the Champalimau Clinical Center in Lisbon. And today I'm here as the president of the Advanced Breast Cancer Global Alliance. Next slide. Just to remind everyone, please participate in this webinar. Send us your questions at any time. In the end of each of the short presentations, we will have time for Q&A. So please use the Q&A button, send in your questions, and we will address them at the end. So without any further ado, I'll pass the floor to Pat Garcia Gonzalez for the first talk.
Thank you so much, Dr. Cardoso, and welcome everyone to this webinar. I'm really excited to share with you what we have learned in this past year in providing treatment for advanced breast cancer in some low and middle income countries. And so my job in the next 10 minutes, since this webinar is about breaking down barriers, my job is to share with you the barriers that exist that make this type of work so difficult and challenging. And before I go into that, I want you to remember that while challenging, it is indeed possible to bring access to treatment to patients in the lowest income economies of the world. We have done it for the past 20 years, especially in chronic myeloid leukemia, successfully reaching more than 100,000 patients. So I just want you to keep that in mind as we go into, the barriers that exist for access to treatment and why is it that we have to really work together. So if you think about access to treatment, it requires that companies actually start by registering and commercializing the product in every country. And what happens in real life, something I didn't know when I started this work 20-some years ago is that when these new drugs come to the market that, we all hear about, by design in their plans, these drugs will never reach patients in like half the countries of the world. In many, many countries, they never get registered. And if in some countries they get registered, they don't get commercialized. So if you're a patient that needs a drug in that country, there is actually no way that you can have access to that drug. Then let's suppose that we have other countries, so especially middle-income countries, in which drugs do get registered and commercialized. Many of these countries do not have universal health care. Government does not reimburse cancer drugs. Most of these products, especially the innovative cancer drugs, are not in the national cancer list of medicines that the government provide. And one of the hardest things that I have seen is in some countries where the government does provide some of the medicines, these programs tend to be substandard. There is no really good forecasting and planning, and patients are not able to receive their full treatment. Now, let's say that, there's another set of countries where patients have private insurance. Well, in many, many countries, this private insurance does not cover cancer drugs. We have seen, and we don't need to talk about middle-income countries, in the US, for example, that patients cannot afford the copay. Many patients don't have insurance and definitely cannot afford the treatment. And one of the saddest things that I have seen in these years is patients that don't have insurance. They sell everything they have, they start their treatment, but then at the end, they don't have the means to finish the treatment, and they pass away, and their families are left at the end with nothing. Now, let's suppose that we say, okay, we're going to overcome all these 3 layers of barriers by sending drugs as a humanitarian donation free of charge. Well, there are countries today that do not allow international donation of medicines. Some other countries, and this happens a lot, when they see the value of these drugs that are coming in, even though they're coming in free of charge for the patients in their country, governments want to impose import taxes to the donors on these donated medicines. The importation process is very, very difficult. We have to get an import permit for every shipment that goes into the country, and sometimes this importation process can take months. So this leads potentially to stockouts. And because you're bringing medicines, let's say from Europe or the US, the regulatory environment dictates that the hospital that receives these drugs needs to be a standard levels of the same as the hospitals in Europe and the US. And it's very, very difficult sometimes for cancer centers in low and middle income countries to be able to meet those standards required to receive and dispense these medicines. So I'm going to tell you that even when we overcome all those barriers I just told you about, then suppose we have the medicines in the hospitals, we are faced with the fact that there are no diagnostic capabilities in many of these hospitals, especially because since there was never access to the treatment, the diagnostics are not there. There was no need to diagnose anyone because there was no access to treatment in the first place. Sometimes we see the infrastructure is there in the hospital, but they cannot afford the reagents. So sometimes we can see that some instruments are sitting there for 2 years, that there has been no reagents. And you have to know that, most, if not all of these governments do not cover any kind of diagnostic, especially molecular diagnostics for cancer. So diagnostic is a very, very big barrier that we need to overcome when we think about access to cancer treatment. Now, I'll ask you to assume that we fixed all these problems. Now we have the issue of the socioeconomic challenges of patients. Many patients cannot afford the hospital consult. Cancer treatment is very centralized in most countries. There is sometimes one national cancer center. Patients cannot afford the bus fare to actually go to the hospital so they can go on with their treatment. Many of them have to stay overnight because they live so far away, and they don't have the funds to have a place to stay. And many patients with cancer in low and middle income countries are day laborers, and so they get paid if they work. They don't get paid if they don't work. And we see many patients that definitely cannot afford to take the day off to go to the hospital for their treatment. And then finally, I have to talk about stigma. Because there is such stigma of cancer, patients cannot disclose their diagnosis many times not even to their family, and definitely not to their employer. And if you cannot disclose to the employer, how do you explain that you have to take the day off to go to the hospital? Patients are unable to ask for that. And one of the most pervasive barriers that I have seen is that in many countries, women don't have control over the decisions around their health. So all this makes it really difficult, from issues of registration of drugs to reimbursement, affordability, the regulatory environment, the diagnostics, the socioeconomic problems, and the stigma. And this is why I have mentioned to you previously that you have to remember that while challenging, it is not impossible. It is actually possible. You just have to tackle the entire ecosystem and the barriers at all levels in any program that you put together. And this is why it's so important, because many of the access initiatives that I have seen, they tackle only one piece, and then they fail. They think that, okay, maybe the problem is that the drugs are too expensive, so we're going to lower the price. Well, that helps, but doesn't solve the problem. And at the end, patients don't have access to treatment. Or registering. Let's say, oh no, we have to fix registration. We have to register all these drugs. We have to put them on the national list. All these are good intentions, but unless we do it all together, patients will not have access to treatment. But after saying all that, I am proud to share that we have indeed been able to launch this program for advanced breast cancer, and that today, since the beginning of the year, patients in 10 of the lowest income countries of the world have access to the CDK4/6 inhibitors and are being treated for advanced breast cancer. We are working on opening the program and reaching patients in at least 3 new countries in the near future. We have reached more than 168 patients that are treated to date. And I think that through the course of this hour, we will discuss more what have been the lessons learned, what have been the barriers that we have encountered specific to breast cancer, which is of course, it takes a whole ecosystem of treatment and treatment specialists to successfully treat breast cancer. So with that, I will give it back to Dr. Cardoso.
Thank you. Thank you very much for sharing excellent overview of all the barriers and levels of barriers. We hope we will also by the end discuss also potential solutions which you have found throughout these years of wonderful work with the Max Foundation. So we will go now for Dr. Alex Eniu. Dr. Eniu, although he lives in a wealthy country now, he has many years of experience of living in a not so wealthy country. So please give us the physician perspective.
Thank you very much, Fatima. Thank you, Pat, and thank you for putting all this together. This is excellent opportunity to discuss how to overcome these barriers. And what I would try to do in the next 10 minutes is to actually show you the perspective from a physician's point of view, and to try to tackle some of the solutions that we have found together with the ABC Global Alliance and PACT. And I would start by saying, why do we care about access? Well, I think as physicians, we are, and as health professionals as a whole, we are very much interested in our results and to see that we improve the results of taking care of patients with cancer in general, and with breast cancer in specifically for this discussion. And what you see in this, let's say, crowded slide is two groups of countries. Here at the bottom, you have countries that have a high incidence of breast cancer. You see wealthy countries like France, UK, etc., etc. So here, about 1 in 10 women will develop breast cancer during their lifetime. In poorer countries, like on the top of this slide, you see countries with lower incidence. Just 1 in 20 women will develop breast cancer. So we would say, well, this is good because, you know, poorer countries have less resources to care for breast cancer, and so it's good that they don't have such a high incidence. But in fact, what happens is that in the more developed countries, mortality from breast cancer is much lower for a various number of reasons, including screening, etc. But you see that, for instance, in these wealthy countries, 1 in 100 women will die from breast cancer, while in the other countries, approximately 1 in 30 women will die from breast cancer. So you see there's a huge threefold difference in the efficacy of the health system to take care of these patients. So this is what pushes us physicians to try to work on this to actually decrease disparities and try to improve the results. And of course, there are many reasons for disparities, and I will not spend much time on discussing this, but just to mention, because the title of my talk is access to medicines, but this is just one piece in the continuum of care, because cancer outcome disparities are also linked to cancer population health and lifestyles. And unfortunately, having as far as the Global Development Index increases in certain countries, that also unfortunately brings up higher incidence of breast cancer, for instance. So that has an impact. The health system infrastructure, a number of hospitals that are there, it's very important. Stage of diagnosis, of course, lack of screening is also extremely important for the results. The cancer care infrastructure, that means the tools that we physicians or health professionals need to treat these patients, are they present or not? Indeed, cancer workforce, and nurses, technicians, all that is extremely important when tackling this important problem. And one element is also access and availability of cancer medication. But this is just to show again that it is important to think of all the components, just because just providing one drug will not change completely the results for the patient, and that we have to be able to offer the continuum of care as it will be further explained. And then there is this, the difference of those who have or have not, and that influences everything that you see on this slide, and that has a major impact on outcome. So just briefly showing, screening is not available in many countries. Pathology, lack of access to diagnostic pathology is endemic in certain countries. I'm showing here just the African continent, but this is a huge problem everywhere. Access to safe, affordable, and timely cancer surgery, which we think it's given, but it's not. And it was said that only 5%, between 5 and 20% of patients have access to safe and timely cancer surgery. And then, of course, what we know about the global inequity in radiotherapy access, and there are countries where there's no radiotherapy machine or one for a huge number of millions of people, and simply access is not there. Now, in terms of availability of cancer medicine, we've done work in the past to evaluate the availability and out-of-pocket cost for cancer medicine across the world. And what I want to show here is that we've underlined an issue that is more and more present, and that is the lack of availability of essential medicines. Those are the medicines deemed essential to treating and actually curing most of the cancers that we have to deal with. And actually, this table shows you that in color-coded, and I will not go into the detail, but basically when you see red and black, that's not good. These cancer medicines that are inexpensive, they are not available because they are either not reimbursed or they are unavailable because of shortages of drugs. And this is something that we should all take care of. It's a big problem even in countries like the US or even Switzerland. Old and inexpensive drugs are in shortage because they are not interesting to be produced. This is not an issue of resources. And again, I think we have to pass the message that these are essential. Of course, we need to have access to innovation, but that takes time, as Pat was showing. And there's a long pathway of incorporating innovation. And we still need to rely on these basic bricks to ensure what I was again saying, this continuum of care for the patient in order to have the good results. One important concept is affordability of cancer medicines for those countries that do not have universal health coverage. And I will show you two graphs here, and I will walk you through this. Because what you see now on your screen is the monthly drug price in US dollars in certain countries for 8 different drugs. And what you can appreciate is that, for instance, I don't know if you see my pointer, but the US has much higher average price than any other country. And you go to the extreme and you see that India has the lower prices across the world as an average. But there's an important but. Affordability, that means how you compare this to the monthly GDP is completely different. So on the right side of the graph, you see that even if in the US prices are, or drug prices are very high, they are still affordable because they represent a much lower percentage from the monthly GDP per capita. Whereas in India, even if the drugs are extremely inexpensive as compared to the US, they still represent on average 1,500% more than the monthly GDP per capita. So that gives you an idea of the capacity of buying for patients of this drug. And this is a huge issue in many low and middle income countries, which of course brings financial toxicity. And financial toxicity is a concept that now has technical terms. It has a start, it has periods. But it basically is related to cancer-related costs that have both an objective, but also the subjective feeling of financial constraints that lead to financial strain, distress, and bankruptcy. And basically, what happens is that everything that a person has, a house, a car, etc., they have to sell that and to pay for their medicines. And in fact, there's a huge problem in many countries, I would say globally, including wealthy countries, with this problem. Patients are not protected, and they have to pay out of their pocket for many things. So, what can we do about this? What are some solutions that we have thought of? Well, of course, within the PACT program that we've developed over the last 2 years, I think we started understanding from the beginning that education of both patient, healthcare providers, but also patients is of extreme importance. And we've tried with Fatima, we've spent hours in webinars, in training sessions for our partners, for our doctors in different countries of the world where this drug, the CDK4/6 inhibitor, would become available, to discuss with them what is new, what are the toxicities, how to manage those. We discussed clinical cases, and that was very enlightening for them. Many of them had no prior experience with this medicine. We continued this training session that were done via telecommunication with on-site training, and we had several site visits. Fatima has done a number of them. I'm showing here a picture from one of the visits we did in Cambodia, where we really sit down with doctors, try to discuss cases, try to discuss their issues, and try to help them in better helping their patients to fight the disease. Please note that both ABC Global Alliance and the European School of Oncology, and you have their websites, provide enduring resources. ABC Global Alliance has a number of extremely good materials, both for patients and for patient advocates, and for physicians. And we at the European School of Oncology, we also have lots of presentations on how to better manage patients with cancer. So I please invite you to go and visit those sites. I think another lesson that we learned besides education was that advocacy is extremely important to bring about change, and that helping, especially in low and middle income countries where advocacy has been less developed and has fewer visibility, let's say, this doesn't really help, and we need to help themselves by teaching them how to do advocacy to really manage to bring change, because politicians and healthcare deciders will listen to this voice. Now, it has been mentioned before, but and I cannot stress it more, we cannot treat anymore any cancer today without knowing the pathology. And we rely very much on what the pathologists will tell us to decide how to approach the disease. And therefore, improving pathology, both in the traditional way, such as you see on the left side here, Jane Brock providing some insights to local pathologists in Cambodia, but also perhaps making a leap forward with these new systems that can provide information when setting up an immunohistochemistry lab is way too complicated with all the difficulties of doing this. I think there are innovative solutions that could help very much the patients in the future. So I will just highlight that indeed ensuring access to medicines is a complex system, as a complex process, as Pat already showed. And although bringing the medication in the country is very good, this is already accompanied by a number of other interventions to improve diagnosis, to improve advocacy, to improve education. So it's a process in which we are proud to be part of. And I think it's just saying we are bringing medicines to a certain country is just the tip of the iceberg of the really huge work that has to be done to make it a successful process. And indeed it is. If you go on the Max Foundation website, you'll see this data, and this is just impressive to me to see the huge number of patients that provided access to medication, and the number of countries where Max is active, and the number of medicines that have been provided. All these numbers means this is feasible. So you have to have the audacity to revise, adapt, continue, and I'm sure together we can be successful. With that, I thank you very much for the opportunity.
Thank you, Alex, very much for your overview and your perspective. And now we go also to listen to the patient perspective. And for that, we will have Carla Ruiz de Castilla, and she's the director of the organization Esperantra from Peru. So Carla, we look forward to listen to your thoughts.
Thank you, Dr. Cardoso. Thank you to Pat Garcia and the Max Foundation and ABC Global Alliance for inviting me to this webinar, educational webinar. Esperantra is a patient organization in Peru who has seen the patient perspective since 2005. So I think the most important thing that patient organizations can do is to advocate for having a healthcare system knowing and helping patients for sure. We have in Latin America cancer laws. So Esperanza helped to have the Peruvian cancer law to give access to diagnosis and to treatment to cancer patients. So we have seen in the years that Argentina, Colombia, Paraguay, and Bolivia have their cancer laws, and that help their patients to have the access. So we hardly work to have our own cancer law. In prevention and early detection, for example, we have seen also that the 67% of the studied countries in Latin America get the highest scores in the discouraged smoking subcategory, and only 83% of countries have a full HPV vaccination program in order to prevent HPV-related cancers. In Peru, for example, each day die 7 women for HPV infections or cervical cancer. So this is very, very sad. And only Chile and Mexico received the top marks in the reduced sugar consumption subcategory, for example, and we have many challenges here. About timely and accurate diagnosis, the patient view is that we feel that delays in diagnosis worsen our condition, so leading to more complex treatments or reduced quality of life. We need to to have diagnostic tools, better training, and better access for healthcare system. About the finance, only 25% of studied countries in Latin America provide universal coverage for cancer care for citizens treated for free. So we face lots of challenges in this. For example, in Peru, we have many types of healthcare systems. We have the subsidiary system, and we have also the social security. In both, we have many challenges to get diagnosis and to get the treatments. About the radiotherapy availability, also we have some challenges. The availability for radiotherapy is a proxy for cancer control, infrastructure, investment, and only few countries perform very well in this domain. Only Uruguay and Chile have enough radiotherapy machines to treat all of their country patients. In Peru, with our cancer law, we know that the government is buying more and more devices to do radiotherapy and to do also screening, and having machines are more prepared hospitals. And about medicines availability, we only have in Latin America 50% of countries making available all of the innovative drugs for many types of cancer, and 0% of countries provide all the novel medicines. We have a lot of challenges to have innovative treatment. Sometimes the system says, for example, that if one drug is in phase 2, it can be reimbursed. But in cancer, we all know that the innovation need faster access for patients when the drug has, for example, FDA or AMA authorization. In our country, this doesn't happen. Yesterday, for example, I had one patient in my association asking for having one drug for breast cancer, which has the authorization in Peru, and it has the FDA and EMA. But in Peru, the private insurance says that this is in phase 2, so it can be reimbursed. You can see here that, for example, red lights in early diagnosis are the main in Latin American countries. And about treatment, we have only red and yellow lights in cancer. So we have to develop a stronger healthcare system that can do better for their patients. This is what we do in hospitals. For example, we can help a lot, but helping patient by patient was a kind of frustrating in our country, because we needed to help everybody, not only the patients that can arrive to our association. So that's why we developed a cancer law to protect every cancer patient in Peru. We did a lot of advocacy, a lot of educational programs. We went to our congressmen, to everybody, to share these challenges and to have a better care for our patients. So this is what I can share to you. I think the patient organizations can do a lot for having a better healthcare system. So I think everybody, doctors, patients, and the civil society together can advance, can really help in preparing these systems to have a better healthcare system. Thank you so much.
Thank you, Carla, for that very sobering and informative presentation about the potential and role of patient organizations and also the challenges that we face. And now, to bring us all together, it's my pleasure to introduce Dr. Cardoso again. So, Dr. Cardoso.
Thank you very much. And my job is just to put some, let's say, take-home messages from all that we have heard, and some personal thoughts as well. So let's see if I can move this. There we go. So when we look at the implementation challenges, we have to think that accessibility to a treatment, as you already heard both from all the three speakers before, even within an access program, the true accessibility to the treatment depends on many factors. Some of them, I'll try to summarize. So some of them are related to diagnosis. To provide the accurate treatment, we need to have a proper and timely diagnosis. And this includes biology, includes type of cancer, because if we want to give particularly the innovative therapies, they are more and more targeted therapies. So we need to know if the target is present to be able to do that. But it's not just related to the tumor. We have also heard that it is indispensable that the patient is able to attend the appointments. It also is indispensable, once we start the treatment, to be able to verify that the treatment is being efficacious or not, and to monitor the side effects to be able to manage them. For that, we need access to imaging and to blood tests as a minimum. We also, of course, need to always have the healthcare provider team knowledge about these side effects of the new treatments and how to manage these side effects, but also from the patient side to be educated about what type of side effects to expect and what they can do themselves to help manage these side effects and tolerate better the treatment. And the new treatment, it's almost, as I usually say, there is no efficacious treatment that has no side effects. If something has no side effects, we have to suspect that maybe it doesn't have efficacy as well. But so if we are going to induce some side effects, we need proper accessibility to what we may call supportive services and medication. So if a drug is going to give nausea and vomiting, we need to have access to antiemetics. If it's going to give diarrhea, we need to have access also to treatments of diarrhea. And I put there pain medication because all treatments need some time to become effective. And in the meantime, a patient should not suffer from pain, since pain medication globally and overall, the most important pain medication is not expensive and could be accessible. And also sometimes we forget that besides all this, we also need to work on the life conditions of the patients. So for example, if we are going to give treatments that will decrease the immune system, are we sure that when we send the patient back home, she or he will have the adequate housing to live if they are immunosuppressed? If they need to change their food because they have GI symptoms, they have mucositis, are we sure that they can afford that, to have proper food adequate to what they are going through? And also fundamental that I looked into as a separate point, and Alex already alluded to these, and the WHO Global Breast Cancer Initiative alludes to this very often. If we start a treatment, we have to work on the ability to keep the treatment, to maintain the continuum of care. Because if we start and then we have frequent interruptions, or if we stop before we end, then we have induced toxicity and we're not going to achieve the needed efficacy. So what about some potential solutions? None of these is easy, but these are some potential solutions that we can all work together. And we have to pass this message about the need to complete treatment. And this has to reach those who take the decisions as well as the patients, for the patients to understand why is it important to continue and to keep the compliance to the treatment. And we cannot just say this is important. We have to provide the support that it's needed for treatment completion to be achieved. And that goes from diagnosis, treatment, and additional financial support. So when we go with this access program, perhaps one thing we can do is to discuss with whoever is making the decisions in the country for them to match the access program with what needs to be invested in pathology, in imaging infrastructure, in human resources, and to avoid shortages, to avoid what Pat has described. You have the machine for pathology, then you don't have reagents. You are not able to do the diagnosis. You are not able to receive the new treatment, even if it is given. So we may also work on support for pathology and imaging within the access program, but this makes the access program much more complex and much more expensive, and it's not easy. And also the additional financial support, for example, transportation to the hospital, perhaps a place to stay near to the hospital if the patient comes from far away, help with the food. We can try to include that in the access program, but again, this is very complex and also increases the cost of the access program, particularly when we think about long-term investment. One thing that we can and we try to do is think about the supportive medicines and perhaps include in the access program for a proper management of side effects, and adequate train all the healthcare professional team about the new treatments, about the side effects and how to properly manage, and at the same time provide education about the same thing about the side effects and their management for the patients. Now, it is fundamental to really continue to and also one of the points that we can do is to promote and support telemedicine. And I put the support because in some countries, if you use telemedicine, that is not paid for, it is not reimbursed, and it has to be out of pocket for patients. And if that is the case, we are certain that the patients will not be able to access. Finally, When we go with an access program, one of the points that we always think about is, okay, maybe I'm not going to be able to be here forever, right? Most probably not. So how can we help and work with every team locally to make sure that the treatment and adequate management will persist beyond the duration of the access program? So again, we have to pressure the decision makers to invest in infrastructures and human resources, because sometimes they invest in the machines and then they forget that the machines don't work alone, and that they need to invest also in human resources. I always find very crucial to teach that we have tools, and we have tools to prioritize, and that, for example, the WHO Essential Medicines list is one of such tools that you can use to see what would be your priority within the treatments. What are the priority treatments that you have to fight to have those treatments, and to have means that you have to have them in a persistent way. You cannot have frequent shortages, like, again, for treatment completeness. And then we can, and there are already methodology available, developed together with the national experts and with the patient groups, resource stratify guidelines or adapted guidelines for the resources in the country. And again, prioritization is crucial, because we cannot go and ask a government of a low-income country to provide everything at once. So we need to help them prioritize what they should invest first. And we discussed about and gave you examples of training, but what I think it is fundamental is to retain the human resources and continue to mentor, support them, whatever we can do, so that the knowledge they acquire, that remains in the country. And for me, and I believe you saw through the speech of Carla, it is fundamental that every country has patient advocacy or patient support organizations. So helping them to create and help them to continue to provide their support is also fundamental. And remember that decision makers listen much more to patients and civil society than they listen to healthcare providers. So it is really crucial. And this maintenance of the continuum of care to avoid wasting resources without the proper benefit. So those are my final thoughts, and I'll just remind everyone to send in questions and comments. Pat, I'll pass it to you.
Thank you, Dr. Cardoso. I really appreciated very much how you were able to summarize, first of all, some of the key components of a successful access program, and some of the things that we can work on, because I think after seeing all these so many challenges, it's easy to think that we should not do anything because it's so complicated, but that's definitely not, we have shown that it is possible. And also, personally, I believe that the lives of every person around the world have the same value, and that we all have a responsibility to ensure that that people, that patients and individuals in low-income countries don't suffer unnecessarily from cancer, because we can indeed help them. So we have seen some comments in the chat. I appreciate very much the discussion. I haven't seen a question to any of the speakers. If anybody would like to ask a question, we're here to answer.
I think perhaps the point that Rancy is doing, Rancy from Project Pink Blue, is very important, that if you do not confirm that it's cancer, you may waste resources and induce toxicity for no benefit at all. So that's why we keep emphasizing that treatment has to go with proper diagnosis. And it's almost wrong, if we may say like this, to start any treatment without being sure that you are treating cancer. And believe, and I'm sure all of those who have experience in the field, there are many other diseases that can mimic cancer. You think it is cancer and it's not. And obviously, it's a very good point that Rancy is making.
Yes, I mean, I think that's the key, right, to the lessons that we learn is that not one thing doesn't work. Diagnosis without treatment makes no sense. Treatment without diagnosis should not be done. And at the end of the day, if you don't help with, you know, the socioeconomic challenges of patients, and if you don't fight the stigma that also, you know, it doesn't work. You can have all the fancy drugs and diagnostic hospital, and yet patients cannot be there. So that's really one of the key messages I believe that I'd like the audience to understand. Now we do have a question for Carla. Hello, Carla. Please,
Hello.
is your organization primarily with volunteers or fully employed, and how is it funded?
Both, Pat. More volunteers, from the universities, doctors, nurses, etc., and also a short employees. I would like to add about your comment. I think the inclusion of cancer patients is important. Not only having access to diagnosis, to treatment, of course, this is the main thing. But after the cancer, what happens when you survive from cancer? The discrimination against cancer patients is intense. At work, for example, they could be usually separate of their work because of the productivity and many other things. Discrimination affects survivors who suffer stigma of having had cancer. They have problems to be hired, to have private insurance, for example, because of the pre-existence. They have problems on the access of bank credits, for example, for continue their lives, and many other things that we need to think about.
Yeah, you're correct. So the work never ends, and we do need to make sure that we work with patients and for patients, and that everyone is able to live their lives with dignity and with hope, we say at the Max Foundation. So Runzi has a question for us.
That's for you, Pat.
And you, what can we, the advocate in Nigeria, do to bring the humanitarian pact to Nigeria? Yes, you know, this is something that we definitely need to, I think what I have learned in the past year to bring access to breast cancer drugs in every low and middle income country is that we really need to start by sitting down with all the stakeholders in the country and map the patient journey and figure out where the challenges are, and then make a sort of a strategy about like where are we going to start tackling some of these challenges. So, you know, we're very committed to patients in every country. You know, one of the things that always makes it hard is the resources available to do this. But Runzi, we should be working together to see if we can do that for Nigeria in the next year.
And Pat, there is a discussion about when you said about the women not being able to take the decision. There is a question if that is because they don't have independence, financial independence, or is it cultural, or is it a combination?
Yes, thank you. In some cultures, women are seen a little bit like possessions of their husband's family. and they don't decide on their own decisions. It's the male of the family that typically decides if it's worthwhile to treat the woman, and that it's not a universal problem, but it is definitely a problem in several countries around the world, where culturally women are seen as sort of less than men.
I don't see any other question. I don't know if any of the panel members wants to address any specific issue.
Yes, I wanted to ask Dr. Inu. I wanted to hear from you. You have been working in this project now for a few months, and we're really so appreciative of your guidance, and you were able to go to Cambodia. So I'd like to hear your thoughts, both on the sort of lessons learned, things that surprise you, and things that you really thought that are on, good parts of the model that you would like to emphasize.
Thank you so much, Pat. I think definitely it was an incredible experience over the last 2 years to work with Max and the ABC Global Alliance for this. I think because of the need that we have to try to improve what is happening in these countries, where you see the difference in mortality, is just something that pushes me forward, at least. And I, with the help of Max and ABC, we really have the feeling that we can change things. I've been working in many years now in let's say health discrepancies, inequalities, access to care, etc. Certainly, most of the work has been to try to improve guidelines or policymakers, to influence them, to do programs. But at this macro level, you never kind of get to see the results yourself. And although this has been a lot of work that has been productive, I think the experience with the PAC program is that it's much more direct. I mean, you identify a problem, and you actually identified huge number of problems with your wall of barriers. But I'm still convinced that we can, eat the elephant by bringing him into small pieces. And within this program, what is very rewarding is that you identify the problem, you look for solutions, you discuss, you try to improve, and you in the end, we have managed, as you have shown, to bring those medicines to the people, to have a selection process by which adequate patients are selected for this treatment. That means the right biology, the right type of cancer, so to speak of, the right biology, then the right stage of disease. And we are seeing results. Of course, this is extremely rewarding to be able to look into, these doctors' eyes when they were happy to explain about the first patient that they had was really fantastic. And then, of course, just to feel that you are part of this effort that really manages to change something for good. I think that's really rewarding.
Thank you so much for that. And I do want to mention, because we haven't, the role of industry that has come and support us and provided, that made their drugs available. The role of diagnostic companies and pathologists that are working with us in providing and elevating the diagnostic infrastructure, the role of patient organizations that are our partners on the ground that can provide services to patients, and so many others. There's a lot more to do. We need to galvanize more stakeholders. We need to make sure, as Dr. Cardoso said, that we involve governments. But I think that we have shown in the past year that it is possible, and that we now need to really bring a lot more resources and partners to this wonderful project so that we can amplify the impact of the work. Somebody from ABC wants to take us to the end?
Yes, so I want to thank everybody that for sharing the experiences, both those who spoke as well as those online, for staying with us and sending you your important comments. Just reminding that this webinar was recorded and it will be made available for those who were not able to join us at the site of the Advanced Breast Cancer Global Alliance. Next slide, please. So if you are also interested in becoming a member, important to say that it's for free. You don't have to pay anything. Please visit the website or contact that email that it's written over there. And I think that is all. So from the ABC Global Alliance, I would like to thank Carla, Alex, Pat for being here, sharing with us the experience, and also to the Max Foundation in particular for creating this fantastic program for advanced breast cancer patients. Thank you.
Thank you so much. Bye,
Bye.
everyone.
Thank you. Bye-bye.